Good afternoon, everyone. It's 4 o'clock, and we'll go ahead and get started today. Thank you for joining us today for our special grand rounds, both in person and online. It is my distinct pleasure to introduce Dr. Adriana Ioachimescue, who is visiting us from Emory University from Atlanta. This is our first in-person grand rounds in over a year for us, and thanks to vaccinations that we are actually able to do this. And, it's really historical, So I don't know, maybe other institutions have done it, at least for endocrinology, this is historical. So Dr. Ioachimescue received her MD and her PhD degrees from Carol Davila University of Medicine in Bucharest, Romania. She completed her residency training in internal medicine at both Danbury Hospital in Connecticut as well as at Cleveland Clinic in Ohio, followed by endocrinology fellowship at Cleveland Clinic. She then joined Emory University as assistant professor in 2007 and has risen up the ranks to be full professor now. She is currently a professor of medicine as well as neurosurgery at Emory University, along with being a co-director of Emory Neuroendocrine Pituitary Center. She has had an illustrious career over the past decade, really honestly very impressive. Both clinical and research interests are in the pituitary disorders, and her main focus is on the pituitary tumor pathogenesis and outcomes post-surgery, radiation, as well as medications. She's also working on validation of some prognostic markers and identification of novel therapies for pituitary tumor. She has had multiple roles, both national and international level, including serving as peer reviewer for several journals, serving on editorial boards, and also on several planning committees at national and international levels. She has had numerous awards and commendations, both from within Emory as well as from national stage. She has over 60 publications, including original observations and review articles, and many book chapters. She told me she's actively editing a book on pituitary disorders throughout the life, and we look forward to seeing it in print very soon. Among her many achievements include presentations both at national and international level, and we are thrilled today to have her join us to give us a talk on age and sex-specific differences in acromegaly. Thank you, Adriana.
Well, thank you for this very nice presentation. Can everyone hear me? Yes? Okay, good. And thank you for having me here. It's wonderful. I think it is it's the second time since the pandemic when I speak live in front of an audience, but definitely the first time away, and this is exciting. So I hope you're gonna enjoy this presentation about age and sex-specific differences in acromegaly. I hope there will be new things that you will learn. I can tell you that this was based on my clinical observations, and then from there I try to learn as much as possible, and I try to figure out on our patient database how things are. So we'll see whether you enjoy it or not. These are the objectives. So we're going to see how age and sex influence on one side, clinical presentation and comorbidities. The second, the biochemical and radiological characteristics. And the third, whether there is an influence in terms of response to treatment of patients with growth hormone secreting tumors. These are my disclosures, which will not affect in any way the content or quality of the presentation. And I'm going to start with a little bit of epidemiologic data, and at some point I need to kind of get rid of the old studies to be able to keep adding to this slide. It's a slide with epidemiologic data in acromegaly, and as you can see, they are listed from the oldest to the newest study, from top down, and many of them come from Europe, and few of them are nationwide studies. And you can see the time interval, and you can see the prevalence, and you can see the incidence of acromegaly in different countries. So roughly prevalence about maybe 385 per million in recent years in terms of the reports, and incidents roughly around 5 per million new cases. So let's focus a little bit on the last case, last paper, which comes from South Korea, and it's a very large study, 718 patients diagnosed between 2010 and 2013 with acromegaly. What you see here is the two genders. You have females in circles and men in squares, and you see how the incidence of acromegaly starts to separate, and this disparity, this increase in incidence in South Korea in females happens mostly in the 50 to 59-year-old group of patients. So when you look at the research about age at diagnosis in acromegaly, the median in older studies was around 40 to 50. And then recent studies, one from Italy and one from Boston, indicate that we might be looking at an older population at diagnosis. And of course, this has to be confirmed by further studies. But in this regional study from the Piedmont region in Italy, the mean age was 51. And at Massachusetts General Hospital, those patients cared at that institution before 2006, their age of diagnosis was around 40, and then after 2006 was 45. We don't know a lot about acromegaly in the elderly, but this is a nice study and is fairly recent. And what we see here is that folks who are diagnosed at age 65 or older seem to have lower IGF-1 levels compared to those diagnosed at the younger age. But we very well known that, you know, with increase in age, there is lower IGF-1 production. So when these authors looked at the difference between IGF-1 levels and their upper normal range, so similar to a Z-score, they didn't find any significant differences. The growth hormone-mediated arterial GTT was also not different, but the tumor diameter was smaller in elderly patients than it was in younger patients. They also looked at comorbidities, and there were some that I listed there: colon polyps, thyroid cancer, adrenal incidentaloma, hypertension, and bone disease. And what they found was that they were more common in patients who were diagnosed at earlier age compared to those who were diagnosed at age 65 or older. So more data needs to accumulate, but it seems that there could be a milder phenotype, at least in terms of the tumor diameter in patients diagnosed later. And it seems like the comorbidities are very important to watch for in younger patients with acromegaly who have more time to develop it. So how about gender? So this is a nice new review from last year by Lenders. And what you see here is most epidemiologic studies. And most of these studies, as you see, show a slight preponderance of females in acromegaly. And it's really slight, 52, 55%. The highest difference was in Spain, 60.8% females. But then there was one from Iceland that had only 39.6 females. Excuse me. But in terms of age at surgery by gender, this is our experience of operated patients at Emory University between 1994 and 2016. And in Atlanta at Emory, patients are offered surgery as a primary treatment for acromegaly unless there are issues in terms of their preference or in terms of comorbidities that would not make surgery safe, which is rare. So the age at surgery is really close to the age at diagnosis because there are not a lot of delays in terms of once they know they have acromegaly, they are referred. So what you see here is that the peak age at surgery in females is in the sixth decade of life, 50 to 60. That's the tall white column. And there are more men diagnosed between ages 20 and 40 than women. When we look at the literature, I've only listed some of these studies, but lenders looked at everyone, and there were about 11 out of 15 that clearly showed that age of diagnosis was younger in men than women. And you can see the differences in different published articles. Overall, lenders thought that the median difference in age at presentation was 5.5 years. That is men younger at diagnosis than women. So how about presentation? Like we tell our students, or we used to tell our students, once you see a case of acromegaly, you will never forget it, and it will all be clear for you and you'll have no trouble diagnosing it. Well, the problem is that if you wait, at least in an adult with acromegaly, for the full phenotypical changes to occur, this is gonna pretty much mean that the diagnosis is delayed. So when you look at the literature, those publications before 1980s looked at found the time to diagnosis of 10 to 20 years. And then those published a little bit more recently, 1980 to 2007 to 10 years. And now I was able to find very few publications between 2000 and 2020, and they found 4 to 5 years. The best numbers come from China. They reported a 4-year time to diagnosis. Of course, it's important how you look at this, like what does the onset of disease mean? And we're going to talk about this a little bit. But I really like the study, and I've presented it several times whenever I had the opportunity because there's a lot to learn. It's a study coming from Sweden, and it's a nationwide database. They're good with this in those countries in the northern part of Europe. And they looked at all their patients diagnosed with acromegaly between, I believe it was 2001 and 2001 and 2013. And what you see there in the left-hand side is the chart that shows the number of comorbidities in relation to diagnosis delay. So these authors thought, okay, if the first comorbidity or manifestation was no longer than 1 year prior to the actual diagnosis, that's going to be without delay, without DD. And then you can see 1 to 5, 5 to 10, and more than 10. So as time goes by, there are more comorbidities that these patients accumulate, which should be an incentive to us to try to bring them to the correct doctor's attention. And then on the right side, you see the standardized mortality ratio. So these patients are compared with general population. And you see how with increase in diagnostic delay, there is an increased SMR, and there is a statistical difference between those diagnosed at the 1 year point or less versus 10 or more. But it's a clear trend at every point in time. The same Swedish paper indicates that about 36% of patients were without diagnostic delay, had no diagnostic delay. And then you can see the other proportions. And it's really impressive that in the 21st century, about 24% of population with acromegaly in Sweden were diagnosed at 10 years or more. And these authors nicely correlated the comorbidities, and because they had a large enough N, they looked at gender as well. So what you see here is that, first of all, what's not shown here is that the mean time from the first comorbidity to diagnosis was 5.5 years. So that's mean. And then if we look at men versus women, what we see is that the women have a longer time to diagnosis. So the median 4.1 versus 2.7 years in men. And they also have a higher number of comorbidities, both at diagnosis, and that is 2.1 versus 1.7 in men, and at any point in time, 4.3 versus 3.7. And finally, also from the Swedish paper, you see who waited longer in terms of their presentation. Local effects with headaches and vision changes, those are the first patients who are diagnosed because they get an imaging study, right? And then if you look all the way down, who waited the longest, we have the neuropsychiatric manifestations. And we're all familiar with neuropsychiatric manifestations in Cushing's syndrome, for example. But actually, there's quite a bit of literature that's accumulated in acromegaly as well in terms of their anxiety, perceived health, and so on. So, and more recently in this patient-reported outcome studies is the brain fog, which has become now a term in medical literature. And the other thing that is listed here is the non-pituitary neoplasms. So these obviously occur with greater incidence than in the general population, but there was a longer time to diagnosis of acromegaly in women who presented with a non-pituitary neoplasm versus men. So what's the patient's perspective in all of that? I mean, it's the literature that is coming out, the PROs and endocrinologists and medicine in general. This is a study from Germany, and they handed out surveys by mail to acromegaly patients, and they found pretty much the same thing that the Swedish folks found as well, that age at diagnosis was borderline greater in women versus men. The number of physicians that women saw in Germany was greater than the number of men, the number of physicians men saw. And then time from diagnosis, 4 versus 1.5 years. And they looked at what specialty was consulted prior to diagnosis. And in Germany, it was the family physician first. And then orthopedists and neurologists are also, those who see these patients for their joint complaints and for headaches and so on. So it's important to look at this in terms of educating non-endocrinologists. And the authors speculated that acromegaly symptoms in women were wrongly attributed to menopause because things like increased sweating, weight gain, and joint pain are overlapping features. And I think this is correct, but I have another clinical scenario that applies to women that I've seen frequently in my practice. And this is my patient who had regular periods, and at age 17, by choice, she went on OCPs for contraceptive reasons. And then at 27, she took a break and she noticed oligomenorrhea and acne. She saw both an endocrinologist and a gynecologist. They tested her. They told her she has PCOS. There was no intention for immediate pregnancy at that time, so the best treatment avenue was to put her back on OCPs, and her symptoms went away. And then at 33, she was ready to start the family, and she had amenorrhea, and she went back to seeing specialist after specialist until the reproductive endocrinologist diagnosed her with acromegaly. And you see here her growth hormone level, which is super high, 138 nanogram per milliliter, significant elevation of IGF-1 as well. And the tumor, what you see here, this is a tumor that is invasive of the left cavernous sinus, and it's a it's completely encircling the carotid artery on that side, NOS4. So at this stage where we are, which is quite advanced in neurosurgery, I don't think any neurosurgeon could remove that in its entirety. So that was the case with my patient, and she did have hypopit even before surgery, and then after surgery, she underwent medical treatment, she underwent radiation, and because she wanted to get off the medical treatment, and she had some side effects, and we are now 13 years later, and I have her on growth hormone injections. So that's something that potentially could have been prevented. Very smart woman, and she did recall that she was having some headaches and some increase in shoe size and some weight gain in her late 20s, but she really attributed those to stress and not being able to take care of herself and work out and so on. So, you know, if you look back, and especially at pictures, I mean, she had classic acromegaly features when we saw her. And when you look back at pictures, you can tell kind of when things start, but that's an insidious change. Features change, and we look at ourselves every day in the mirror. So, yeah. So what are other differences regarding manifestations in terms of gender? This is a large French study, and it turns out in France, women have more headaches than men, women with acromegaly. They also complain more of constipation, and I'm not sure if this is like an ultrasound testing bias, but they have more thyroid nodules than men with acromegaly do. On the other hand, men seem to have more prognatism, to complain more often of erectile dysfunction compared to women complaining of vaginal dryness. They definitely have more sleep apnea. This has been shown in study after study than women, and then heart failure in this study. Another study, only smaller, looking at differences in manifestations, and what you see on the in the upper graph is that numbness and sleep apnea are more frequent in men than women, and numbness is more severe in men. So the lower graph is about severity, and hyperhidrosis is more severe in women. So I think I'm showing you this because I think we need more standardized tools in terms of quantifying the acromegaly features, and perhaps even coming up with some scores that could help the internal medicine physician, a primary care physician, to suspect this sooner. How about metabolic syndrome? Well, I think there is sufficient data in the literature to say that it has higher prevalence in women with acromegaly compared to men. And I like the study. It's one of the older studies that I'm presenting, but you can see here that metabolic syndrome in itself, or any of its components from waist circumference to HDL and so on, were present to a higher degree in women versus men. And the only problem with this study, they did not think to control family history of diabetes, and women had a little more, so that could impact their findings a little. But what I really like about it is how they showed the visceral adipose index in women, which was higher than in men with acromegaly at every age group. And to me, this is the main parameter that would correlate with increased cardiovascular and all-cause mortalities. Not so much the weight in itself or the BMI, is really the visceral adipose index. How about carpal tunnel syndrome? So we're talking about CTS as a presenting sign, and this study from Sweden again indicates that patients who required surgery for CTS, so that was quite a severe CTS they had. If you look here, majority of them had surgery before the diagnosis of acromegaly, which is represented with the dotted line, vertical line. And even as far as 8 years prior to diagnosis. So we really have to be careful about CTS and what else is going on in that person, especially as a young person. Could we suspect acromegaly in that person? And they found it was it was 6.6 times greater, the risk of surgery for CTS than control, and also that women had higher risk than men. more about comorbidities. So I think I demonstrated you to some degree about the glucose metabolism abnormalities. I didn't present the data about neuropsychiatric, something that is more prevalent in women than men, and on the other hand, more prevalent in men, sleep apnea and vertebral fractures, especially in those men who also have hypogonadism, but not only. And then to be determined, I'm not quite sure. There were articles pointing in both directions whether non-pituitary neoplasms are more frequent in women or in men. But in Sweden, they are definitely more frequent in women. How about quality of life? There's a lot of literature coming out here. There are lower scores in women for mental, physical appearance, and relationships, and very few studies that show that both men and women were equally affected. Now, the good news is after the biochemical parameters are normalized, the quality of life improves. However, it doesn't normalize. It's not back to the control scores. And the joint complaints keep men from having scores back to normal, where emotional problems and perceived health over time seem to be the main issues that women are struggling with over time. And I think that's important because you need some partners in terms of neurocognitive, neuropsychological help for these patients, and it's important to know what they are dealing with. Other associations: longer disease duration, radiation therapy, also chronic medical treatment, especially the monthly injections, especially if the patient needs to go back to see a nurse or a physician for frequent appointments, take time off from work, and so on. Those are associated with worse quality of life. Persistent hypertension, pain. There is no question here that pain would make anyone's quality of life worse. Physical disability and hypopituitarism. So I would like to wrap up this part of my presentation saying that rather than teaching students about the features of acromegaly as the main thing to look for in a patient who might have acromegaly, of course they need to know the features, but they need to know about suggestive clinical scenarios. So carpal tunnel syndrome in young patients with hyperglycemia, that should be a red flag. Or oligoamenorrhea, so regardless whether that's a young woman or whether it's a perimenopausal woman, if there is, if with that problem, there are other things such as joint pain or carpal tunnel syndrome or hyperglycemia, perhaps that IGF-1 should be checked. And then I'm going to show you just one graph about pituitary incidentalomas. This is, again, our experience at Emory. So, we looked at patients treated between 1994 and 2016. So you can do like a best split type of analysis and figure out what's going on. And as you can see here, after 2011, there were fewer patients who came to the doctor's attention due to classic feature changes, classic acromegaly presentation. And there were more patients with incidentally detected growth hormone secreting tumors, and hypogonadism was another thing that made some urologists and reproductive endocrinologists to check that IGF-1 level. So, it remains to be determined how to approach all this. But the Endocrine Society and ACE both say, check an IGF-1 when a pituitary mass is incidentally detected by MRI. And what we were able to look at is why the imaging was done. And by far, close to 50% of these patients had ENT complaints, such as ringing in their ears or voice hoarseness, and so on. So that's an important thing to teach our ENT colleagues about this. So how about the biochemical and radiological characteristics? This is a study in healthy adults, and it's a large study. And what you see here is M from males, F premenopausal females, F pre-OC, females who are premenopausal taking oral contraceptives, and the last one on the right is F postmenopausal women. And you see the growth hormone nadir during OGTT, and you see how spread out they are in premenopausal women, and in particular those who are on oral contraceptives. And then what do the red dots mean? These are the patients with a close to ideal BMI, less than 25. So you can see that the spread is influenced by the red dots, with one exception, the premenopausal women on oral contraceptive. Those, that wasn't an influence. So this is just to kind of make us pause and think about our diagnostic criteria and about our remission criteria, and how we like to pick a number and set a threshold, and the lack of standardization of the growth hormone assays is not helpful either. But there are things that we don't take into consideration when we interpret a growth hormone suppression test, and if it doesn't make sense clinically, or if the IGF-1 points in a different direction, maybe it's this. How about IGF-1? I love this study. It's one of the oldest that you'll see in this presentation, but it was large enough. This the study coming from England in 2001, and they looked at males with acromegaly, open circles, versus women, closed circles, and you see that for a certain growth hormone level, the IGF-1 is much greater in men than it is in women. And the difference on average was around 80 nanogram per milliliter, but if the women were taking oral contraceptive, that went to 130 nanogram per milliliter. So we're starting to kind of, in my mind, we're connecting the dots a little bit. I mean, IGF-1 is what causes that facial deformity to occur, and what causes the acron enlargement to occur, and what makes the diabetes come into play. Even though growth hormone per se has a role in some comorbidities, but you heard before, women are diagnosed at older ages, and they see more physicians. They're diagnosed later. Their IGF-1 are lower, so there might be a reason for that. It's not just a physician who's not well trained. And we reproduced exactly the same thing with our data at Emory, where you see females in blue and males in red, in terms of the relationship between pre-op IGF-1 on y-axis and the logarithmic scale for growth hormone. And that's not the nadir to GTT, that's just baseline growth hormone. So the mechanism of sex differences is known. We know that testosterone enhances both the growth hormone secretion and action. If you have, I'm sure you saw those consults of men who were taking a large amount of testosterone by injections, whose IGF-1 level was above normal, and they didn't have acromegaly. And then we also know that the estrogens reduce the growth hormone action. So the effect is more like they cause a little bit of growth hormone resistance at the liver site. And those studies that performed age and gender stratification support these findings, because the difference between males and women seem to be explained by the younger patient population, in women's case, premenopausal. So this is our data in a nutshell. I've told you already about the age being older in women than men at the time of surgery, which is close to the time of diagnosis. But what I haven't told you so far is that we also found that the tumor diameter was larger in women than in men. So again, going in the same line of a later diagnosis, more comorbidities, and larger tumors. During that time, the tumor grows. We couldn't find any difference in terms of cavernous sinus invasion, and the mean IGF-1 level was lower in women than it was in men. No differences with regards to pre-op GH levels. This is a larger study than ours, and it comes from South Korea, and they were able to do age and gender stratification. They had close to 470 patients in here. And the only differences that are statistically significant are in the young patient population. Again, lower mean IGF-1 levels in women and greater tumor diameter, mean tumor diameter in women. They also found, because they had a larger N, they also were able to do NOSP stage stratification in terms of invasion. And they also found that women had more invasive tumor than men. And look to the right, there are no differences. So after age 50, they couldn't find any differences. But look at the end there. I mean, they only had 37 males in that group. So, of course, if you add more, things could change. This study comes from Massachusetts General Hospital, was published last year. And what you see on the left was tumor size at diagnosis is the same, mean tumor size is the same in men, regardless of the age quartiles. So that as age went higher, there were no statistical differences in terms of the tumor size. And what you see on the right is the female situation, where the young women, younger than 33, had larger tumors on average compared to those older than 44. So how about treatment outcomes? Well, the South Korean study that indicated that women had larger tumors and a greater proportion of invasive tumors to the cavernous sinus also found that premenopausal females have the lowest postoperative remission rates. And they looked at this in the short term, like 3 months post-op, and also in the long term. So they maintained the same disadvantage. And what we don't know is how were these patients followed and treated. They didn't share this in the article, but they didn't seem to do as well compared to postmenopausal women or men at any age. Now, I want to tell you, as someone who looked at this in great detail, I mentored a younger endocrinologist from NYU to do this, to write this paper in pituitary, that there is no other study so far that found gender differences in terms of surgical outcomes. But this is the largest. This is in close to 500 patients. So that's what the South Korea article says. We did not reproduce that. Our outcomes at 3 months post-op were exactly the same in men and women. But remember, the cavernous sinus invasion was no different. And what you see here is a Kaplan-Meier curve in men versus women, and men are represented in red, so they're not doing as well. Now, this is not all death, okay? I put in here on purpose other events, such as recurrence by biochemistry, and then reoperation and radiation, because the reason why one may have reoperation or radiation, even though it's not necessarily biochemical recurrence, might be tumor progression or the fact that they weren't tolerating or the meds were not effective, right? So if you see here, it's the females who actually do better. But women were coming back to our clinics more than men. So I'm not quite sure whether that's that apprehensions to one's health, which is described as one of the neuropsychiatric issues that happen in women with acromegaly, is what brought them back to our clinics over and over. And if I look at, if I think of individual patients, I can tell you that I have patients, once their headaches and joint pain were gone, men did not really feel the need to come back to the clinic because they weren't as bothered by it. So maybe it's that. But at last follow-up in our clinic, those patients, treated by us at Emory, 89% of women and only 72% of men were in biochemical control by multimodality therapy. So whatever there were those who maintained remission, and then there were those to whom we added meds, and some needed radiation too. So how about medications? Now I like this slide because it shows how much we evolved and how exciting it is to be a pituitary endocrinologist in 2021. So the first FDA approved medication for acromegaly was subcutaneous short-acting octreotide, and then 10 years later we had the octreotide LAR, and then we had pegvisomant, which is still the only growth hormone receptor antagonist approved by the FDA. That was 2003. Then we had another somatostatin receptor ligand targeting the subtype 2 somatostatin approved in 2007. In 2014, the multi-ligand came, and that is pasireotide, which has a 5 subtype receptor 5 as well as subtype receptor 2 affinity. And then in 2020, I've thought a lot about whether going in circle. I said, no, a line is more appropriate. Octreotide again, but this time it's an oral capsule, which is just amazing, to have a peptide administered by mouth. And we use cabergoline in our practice, but it's not FDA approved for acromegaly. It's approved for prolactinoma, and it may be effective in those patients with mild IGF-1 elevation, either alone or in combination with somatostatin receptor ligands. So what do we know about age and gender influence on the efficacy of treatment? For octreotide, they've shown back in 2002 that men need higher doses than women. And that makes sense because estrogen upregulate the subtype 2 receptor. And then with lanreotide, we have a lot of studies published recently, not a lot, but a lot more than before. In terms of predicting outcomes, we have a lot of literature coming out. And this was a study where lanreotide was used as primary treatment. So in Europe, they do this a lot more than we are doing it here. So no surgery. And what they found here was that older age and female gender was a predictor of response to lanreotide. And another study, even more recent, was able to confirm the influence of age. And they are saying that if the patient is 40 or younger, don't count on single therapy with octreotide or lanreotide to normalize the level. There are other factors. I mean, the higher the IGF-1 at baseline, the lower the likelihood that the octreotide or lanreotide would work. And then the imaging is helpful too, the T2 hypointense signal. In this study, gender did not make it as an independent predictor in the multivariate analysis, but it was smaller, 51 patients, so still to be determined. How about pegvisomant? Okay, so what we see to the left is the concentration of pegvisomant in patients treated on y-axis and how it correlates with baseline IGF-1. And the first observation, even though they didn't draw the lines, and I didn't want to draw them for them because I couldn't redo their stats, but the correlation is better in men than it is in women. And then on the right, they found that men had higher body weight than women, which is probably to be expected, and higher IGF-1 levels. But then when they looked at the dose of pegvisomant per body weight, so milligram per kg, it looked like women required a higher dose of pegvisomant than men. And just 2 slides about survival in acromegaly and gender influence. I mean, we could have like an hour talk only about survival in acromegaly. This is a study coming from Finland. Again, these Northern Europe countries where everyone gets into this one database, and if you have a disease of any kind, you're in there, and the statisticians can look at everything. So what does the graph that I showed you here shows? It's a Kaplan-Meier curve, and it shows men and women with acromegaly. And the women are represented in black and the men in gray. So during I'm using their words because it's very impactful when you use it like this. During the first 2 decades after diagnosis of acromegaly, more men than women die. And in this particular study, similar to what I showed you before, men were diagnosed at a younger age than women. Whereafter, more women than men die. And you see how the 2 curves kind of intersect and switch. So what they found here was that survival was dependent on age at diagnosis, and this gender survival interaction was was valid for 20 years post-diagnosis. Radiotherapy in this group had a negative effect on survival. This is not in all studies in acromegaly patients. And then the last known basal serum GH level. So, if the patient was in control or not, which makes sense. And in the same study, now you see men to the left and women to the right compare with the control group. And compare with the controls, mortality is increased during the 20 years of follow-up. But if you look at the gender graphs, it's clear that this happens on the account of women. And as time goes by, more women with acromegaly die than controls. And what's not shown here is that the cause is shifted. So there is more cancer mortality in recent years in acromegaly patients that compared with controls, while cardiovascular mortality, which used to be the main reason for these patients' death, is not as prevalent. And there are a couple of other studies, one from South America and another one from Europe, that point in the same direction. So overall, I would like to say that since so many methods of treating acromegaly have become available, overall the mortality improved. So it's almost close to control if the biochemical control is achieved. So in summary, a constellation of suggestive manifestations or scenarios, whatever you want to call them, rather than striking physical features, should be emphasized when we teach folks about acromegaly. Premenopausal women, I think we've shown you quite a bit of data to say that they have delayed diagnosis, larger tumors, and a greater burden of comorbidities than men, in particular with the what's related with the metabolic and neuropsychiatric manifestations. Lower IGF-1 levels in premenopausal women are explained by the estrogen effect on the GH receptor. There are some comorbidities that affect men and women differently, and I want to point out that sleep apnea is definitely affecting men more than women. And then the doses required to control IGF-1 with somatostatin receptor ligands and pegvisomant are to some extent influenced by gender. This doesn't mean we shouldn't treat men with SRL as our first line of treatment. It just means that we have to take into consideration all factors and make sure that the follow-up, we don't count on them just being in control and see you in 1 year. You just need to do this more often. So what are the action points? As you can see, I'm very passionate about bringing these patients to the neurosurgeon's attention, because I think that's what needs to happen. And first, as primary treatment, we get so much information from the pathology as well, and it's so much easier to control the disease when you're not dealing with an IGF-1 that is significantly elevated. So we want to decrease the time to diagnosis in premenopausal women, and we want to educate not only endocrinologists about this. We want to be careful about the elderly population. If indeed they have a milder phenotype, perhaps we're not diagnosing it. Perhaps we're just kind of following these folks with diabetes, hypertension, and joint disease, and not look for an overarching diagnosis. Seek and manage comorbidities before and after remission. They will not all go away. And conduct multicentric studies in the United States, where we could do better with this, to understand the impacts of sex on mortality. And I think racial and ethnic backgrounds have not even been tackled. I have a project that I submitted for publication, and I hope it will be accepted, because there are definitely big differences in Black versus white patients in terms of their presentation and their IGF-1 levels. And of course, I need those to be confirmed by others. And that was it. This is Emory University School of Medicine and a hospital where our patients are treated. Thank you so much.
Thank you, Adriana. This was fantastic. So we're open for questions.
Yes, Dr. Finn.
You're too young to remember, but back in the 70s, progestins were being targeted as potential therapy. I think they were actually used. There's probably some studies out there. How do you roll that into these findings? And then the other thing there's been a report, I think, in the last few years from a group in Brazil of using clomiphene citrate
Yes.
as an adjunct to therapy.
In men. In particular, in men, it makes a great sense because it would definitely improve.
So is that, again, the estrogen? It's a serum, I assume it's...
Yeah. With clomiphene, it makes sense. It's an estrogen modulator, and it will check both boxes for men with acromegaly. So their testosterone will improve and their IGF-1 will reduce, and that data from Marcelo Bronstein is pretty convincing. I actually was able to visit with him a few years ago, and I was just so amazed to see how every woman there was going on a high estrogen OCP. I must say I need to research the progestin part. I don't know about it, but yeah, I'll look at that. I don't think anyone is working on this right now, but I know we're using these low dose estrogen OCPs and today, but in Brazil they were really reaching out for the older versions for the high estrogen because they don't necessarily. I mean they don't have Somavert or pegvisomant available to them, so they pretty much just have cabergoline, clomiphene citrate, and octreotide LAR. Maybe now they have an andreotide LAR. Yes, they just add the oral contraceptives if this is premenopausal women, or if it's safe to keep them on HRT afterwards, just to try to get to that IGF-1 level.
Do you have any sense that there's any difference in gender with radiotherapy responses to radiotherapy?
No, not yet. I don't think we see. I think the radiation oncology folks have just started to work on this in terms of trying to identify predictors, and I think the main predictor in terms of acromegaly is the dose that was used, as well as the IGF-1 level at the time when the tumor was treated. They didn't get that far to figure out the gender contribution, because you have to look so many years after radiation for acromegaly. It's not like Cushing, and Cushing would be easier, right? If there is effect, it's in the first couple of years, and it's really easy to get at it. But for acromegaly, you have to look 5 years later.
Could you repeat the question, because I think we don't know if people online can.
So Dr. Finling's question was about the role of estrogen, progesterone, as well as clomiphene citrate on biochemical control of acromegaly. Yes.
So that was really an excellent talk, Adriana. At the cost of making some fun of myself and other neurosurgeons, I have to say it's nice to see a thoughtful presentation where every other slide is not an MRI scan. So,
or a movie.
Yeah.
But those are fun. I mean, you guys know that your presentations are always more fun than the endocrinology presentations.
Well, I do have a question, and you know, obviously one of the action points you stressed was education of students and family, other subspecialty or non-specialty physicians that are likely to see these patients. Another disease entity that I personally am very interested in is cervical myelopathy, where there's a slow and insidious progression of symptoms and often a delayed diagnosis, such as that you described in acromegaly. And what we and others have tried to do is come up with a clinical prediction tool or an algorithm where we weight clinical symptoms as well as imaging findings, and then try to use this tool based on a weighted evaluation to see which patients are likely to progress and which patients actually have myelopathy and so on. So based on all of the retrospective studies that you shared, has there been any attempt to weight those clinical features, whether it's in men or in women, to use that as a guide? You know, when people come for their annual physical exams, for example, that can sort of that can sort of like shorten the time to diagnosis?
There was one attempt that was okay. So the question is, has there been an attempt to put all these manifestations of acromegaly in a score that an internist or a non-endocrinologist could use in order to bring acromegaly to light sooner? So as far as I know, there was a study that was published a long time ago, I believe around 2007 or so, that put together some entities such as hypertension, thyroid nodules, acral enlargement, and so on. It doesn't have a name, and it's not frequently used. So there is one score that exists that I found in my literature search, but they are not using it, and I don't think is weight. Like you need to put some more emphasis on some symptoms than others. And what the other thing that could be done, and again, the literature from China has come in that direction, is to use artificial intelligence and look at pictures and features. So we all know about anthropometric features, which change with age, are different in men versus women, and they are definitely impacted by race. And that's why I was saying that many of my clinical projects started from my observations in clinic, and it's not as easy to find to detect acromegaly in early stages, for example, in Black patients, because or even those of Hispanic ethnicity. They're wider faces, different measurements there in terms of nose and other things. So I think we are going to be in a better place with the use of statistical tools and artificial intelligence and putting everything together. I think medicine in general is shifting away from like a dichotomizing things, right? Like, do you have did your shoe size increase, and do you have prognatism that is new for you? I think when we put everything in a score and an algorithm, we're going to be able to do this. But no score is currently used in primary practice, as far as I know. What do you think? Have you? No. I mean, the thing is, the visits are quick everywhere. So I think whenever you try to do scores, like even things like adult growth hormone deficiency questionnaire in those patients who we know had radiation and their IGF-1 may trending down. I mean, even doing that, it takes time. So I think we need to figure out a way to provide clinical care with some quality research intent where we incorporate everything. I hope I answered to your questions. I'll send you the paper with their score, because I looked at it and I was like, yeah, it looks okay, but it doesn't have that thoughtfulness about it in terms of how you could weigh things. Because look at just thyroid nodules in women. I don't think that should matter too much, right? In a woman in her 40s or 50s.
About polyps.
Yeah, I think that's important.
Any differences?
No, not that I could find. Just what I showed you for. So colonic. The question is, are colonic polyps more frequent in men versus women? I couldn't find that. But acromegaly patients, the longer the duration, the higher the likelihood to have all sorts of non-pituitary neoplasms, such as thyroid nodules, colon polyps, and adrenal incidental findings on the MR. And I have so many acromegaly patients who have adrenal incidentalomas that I almost think that I should figure out a way to write them up. But the problem is I don't order that CAT scan. I mean, someone else orders it when they present with abdominal pain or low back pain, and here it is. And I have another thing to work up. But yeah, it's important.
Sorry, go ahead.
Wonderful presentation. I have a practical question for you, and I think it might stem from the acromegaly community is very strong. It's probably, I think, one of the strongest organizations. Cushing's is also very strong. But do you have, I have a difficult time, do you have the same problem? They get so, they feel so secure on the injectable somatostatin receptor ligands. I have a difficult time when I mention going over to the capsules. It's like they don't want to go. They want to stay there because they feel secure and things are finally normal you have the same problem? Do you have a way of getting them to the capsules or?
Yeah, so the question is, it sounds like Dr. Moss is when she presents to the patient the new option approved last year of oral octreotide to those patients who are in control on injections with somatostatin receptor ligands, there is some resistance. They don't really want to change the winning team, so to say. I have experienced exactly the same thing in the last year. I mean, it just depends, right? Taking a pill twice a day on an empty stomach, right? I mean, it's not once a day, it's twice a day. And we all know from studies done in any other medical diseases, including hypertension and diabetes, when one pill a day, that's much higher compliance than 2 pills a day. So, and they are in control, then they might not be bothered, right? We're not in Germany. The nurse comes to their house and they deliver their injection on a Saturday if they want, if they have an insurance company that is doing that. I mean, there are some who come to our clinics, but those are not as many. I just think that it's not for everyone. My patients who switched, they had some bothersome diarrhea or upset stomach after each and every injection, not just in the beginning, or they just wanted to stop being on injections because the injections really bother them, and so on. So those are the two things but that's anecdotally. But yeah, I can hear, I can echo your observation, and I almost think, whenever something like this happens, I want to look from the other angle. So if we were to have a medicine as effective that you take twice a day by mouth, and then you would come up with a medicine that is injectable once a month or every 6 weeks, would that seem an improvement to that patient? I think it just depends on individual perception of injections.
I think you're just afraid, losing control.
Yeah.
So I think we're almost time, but just I had one question, couple of questions. But so you said that it takes longer for women to be diagnosed. It's almost like I would have expected the other way around, right? Because they would have menstrual symptoms and also, facial features. Why do you think it's almost opposite as to what you would expect? But I'll also complete my other question. You had shown that, the data after 2010, most of them were incidentally, diagnosed with, not with classical features, but with more subtle features. Is there an increase in incidence of acromegaly in these later years? I mean, has it gone up? I mean, I haven't seen.
Right. Yeah, very good question. So the first question is if oligomenorrhea and amenorrhea are a presentation of acromegaly, why are we seeing this? Because women would usually seek help for this, which is not the case in men who may not really come up with their issues in terms of sexual desire or function. And this is correct. And I think women are seeking help, but I think there is this overlap, and PCOS and acromegaly have this hyperandrogenic look to them, and PCOS is frequent, and unless the woman is going to say, I need to build a family, then they just get oral contraceptive and they get a little better, and their IGF-1 will get a little better. So it's like reinforcing the same thing. So I think that's my explanation at this point of delay in women. Not that they are not seeking help, but they are just being offered metformin or oral contraceptive. And there is one study that looked at the ovaries of women with acromegaly, and they have this polycystic appearance. So it's even more reinforcing the same diagnosis. And then the second question is whether incidence of acromegaly is increasing at older ages. I showed you all I could find. So I think the only argument for this is to see that the median age in the recent studies is moving up. So probably this is the case, but we don't have, at least in the United States, we really should get our efforts together, and several centers have our databases and try to figure out this issue. But there are signals, right, surrogates that this could be going on as folks live longer and we pay more attention to diabetes and high blood pressure and cardiovascular disease. Maybe someone is going to notice some subtle changes. I keep telling my students, please ask for pictures. Please, if you have the smallest doubt and you get the smallest signal that this might be acromegaly, just ask for pictures. And same for Cushing. I mean, it's just amazing to look at pictures. You'll know exactly when the disease started, and that's helpful to figure out what it is. Is it pituitary or something else?
Thank you very much.
Thank you.